So here it is. Thank you for waiting. Cardiovascular Emergencies, Chapter 16. There's a page in your book, page 628, which actually lists under cardiovascular the National EMS Education Standard competencies. And there's 7 or 8 actual conditions here we're going to look at. But it might make it easier if you just look at that page as well, so you know exactly that you're going to see this information again. So I'm going to bring this over here. Let this finish loading, and we can get underway. So cardiovascular disease is one of those specific ailments that we deal with in the Mod 4A, right? I know we did that introduction or medical overview. The first one, the lecture that you saw on this was the respiratory issues, and respiratory and cardiac really go hand in hand. So as we go through cardiovascular disease, leading cause, killing Americans since 1900, account for 1 out of every 3 deaths. Do the math, that's 33%. So again, 33 out of 100 people are going to die of heart disease. So it's a pretty big thing. It's something that it's not uncommon to respond to, certainly. Now, what can you do, and this is always before, not after the fact, that encouraging the healthy lifestyle, right? Probably shouldn't have mama's pizza or big steak every night for dinner. Okay, that's that encouraging the healthy lifestyle, working out, and understanding that you yourself have to be fit in order to, run a lot of these calls. That's why there's physical assessments, which are now being done for EMS, because it's high stress, it's high physicality in the job. There's a lot of stuff that goes along with that. And so obviously we want to keep yourself safe as well, because it always comes me, my partner, and then we worry about the public. But how can we reduce these deaths? Well, train people in CPR, right? The more people know about CPR, the more inclined they are to and willing to help someone. There's technology and dispatch and response. Some things include something referred to as telemetry, or actually being able to send a picture of the EKG to the hospital. So when they get them in, they're not stopping and doing this, right? They know they may go straight to the cath lab. And when I say cath lab, catheterization is just something that can be done to the heart to help restore the blood flow to it. Public access defibrillation, you might have heard about this in your CPR class, that's PAD. It's just making those machines available to the general public. In addition, an AED is something that is carried on most ambulances. I should say all ambulances, but I'm sure there's a couple that may not actually have those. I know a lot of the cops carry AEDs as well. We do recognize the need for advanced life support. Advanced life support uses different algorithms and can manually shock someone versus typically just the automated external defibrillator. And if we have it, we used to have something here called Tucson Heart Hospital, right? Tucson Heart Hospital is a big parking lot now, but that's an example of a specialty center where you may be able to take your patient. Again, between UMC and St. Joe's, they've all got the ability to deal with cardiac issues and should also all have the catheterization lab. So the heart itself and what it's responsible for is not clicking through these slides so quickly, but actually going back, because I didn't want to skip that. Don't want that. There we go. So pardon the blunders, but after I recorded chapter 13 several times, we're just going to find a way to get through this. And again, as we have those times in class, again, specific items that you need more information on, again, take that time, the question and answer period. I don't expect everyone to watch this or just read the book and say, oh, I got it. So again, we know there's going to be some question and answers that come up from a presentation such as this. But your heart's job, pump blood. Every organ, every cell, all parts of your tissue need that blood supply, and that's the job of the heart, is to actually pump that. There's the left side of the heart, the right side of the heart, and we'll see what those specific differences are as we move through this presentation. So, little picture setup of the heart here. Again, there is what's referred to as a superior and an inferior vena cava. I always think of the superior. Well, what does superior mean? It's above. So that's a way you can equate that, something that just clicks. And the inferior vena cava is actually coming from below. That this is the way deoxygenated blood is returned to your heart, right? It comes from the upper portion, superior vena cava, the lower portion of your body. It's going to bring it into the inferior vena cava, and then it can be delivered into that right atrium. From the right atrium, and there's valves associated with each of these, but it will travel down to the right ventricle. If you ever get confused, A comes before V, right? So the atria are up here and the ventricles are down below that. It'll then slide itself over to the lungs where it can pick up its oxygen. When you look at the left ventricle of the heart, that is the thickest muscle of the heart, and it's responsible for pumping that blood over here to the aorta so it can subsequently be distributed throughout all parts of the body. So kind of just recapping what I told you, the atria does receive incoming blood and the ventricles pump that blood out. There's one-way valves in there. If you've ever heard of the term a heart murmur, my dog has a heart murmur. I just found that out. I'm okay. But when that heart murmur happens, it just means there's a backflow of blood going through that valve. And again, this may be something that the patients live with a long time. It may be something that's new, depending on erosions of certain vessels in there. But the whole idea is the aorta is that body's main artery, and it's going to receive that blood from the left ventricle and then pump it out to all parts of the heart. Another illustration of that where you can kind of see the blood flow and how it makes its way through the heart. But that's something, honestly, I think it's easier for you to see in the book itself. So it's kind of hard to, grasp that in here. So again, I'm on chapter 16, page 628. And to kind of make your way through as we're looking at this, there's some great stuff later when we start dealing with plaque over on 636. So I'll see if I don't remember to reference that page for you. So the heart has its own blood supply, and it also has its own electrical system. It controls the heart rate, coordinates the atria to work along with the ventricles. There is this process called that automaticity that does allow for that heart just to spontaneously contract while it doesn't have to have stimulus from another nerve source. The heart is amazing. And when you think of the heart's primary pacemaker, I don't see the word pacemaker used here right now, but the heart's primary pacemaker is the SA node. The SA node stands for sinoatrial node, and as long as that continues to beat, which is responsible for beating somewhere between 60 and 100 times a minute, then the other pacemakers of the heart will continue. If there's no impulse from the SA node, then what will happen is the heart can go down to something referred to as the AV node, atrioventricular, or it may even just be firing what we refer to as escape rhythms if it's simply Purkinje fibers, but that's something that's not going to sustain life for your patient. So here we go. There's the SA node, sits at that top right side of the atria, and as this impulse is created, it will eventually come down here to the AV node. It slows down, but that's that pushing and pulling motion that takes place in the heart. The Purkinje fibers, almost think of these as just little hairs that just help those ventricles contract. But there's left and right bundle branches. And again, as that SA node starts to fire, it will continue to follow that path of electricity, which is really awesome because we can see that in EKG and electrocardiogram, more of the cardiac monitoring side where paramedics come into it. But the heart itself does have its own electrical system, and it has its own blood supply as well. The autonomic nervous system, the ANS, this is going to control involuntary activities, right? If you think back to, I think it was chapter 5 is medical terminology, so it's probably 6 in the human body. We've got the sympathetic and the parasympathetic nervous system. But remember that with the heart, we're dealing with the autonomic nervous system, and that's going to control those involuntary activities. I don't have to stop and think, I wonder if I should make my heart beat right now, right? It's going to happen all by itself on a healthy patient. It's when they have issues associated with that, that's what we're here for. So the myocardium, and that's the muscle that it does surround the heart, it does have to have this continuous supply of oxygen, right? That's when we think back to those slides, how long can the body live without oxygen? Well, when you're talking about your skeletal system or the integumentary system, you might be able to go a couple of hours. But when the heart is deprived of the oxygen, even for seconds, it starts to show this irritability associated with that. So what the heart can do, the increased oxygen demand by the myocardium is supplied by that dilation of your blood vessels, right? It makes this bigger, and now those coronary arteries can keep the heart fed. Stroke volume, how much volume of blood is actually ejected with each ventricular contraction, right? This is each ventricular contraction, not over the course of a minute, but simply during one ventricular contraction. And there's a formula in here that we'll look at, which you may want to make notes about, but I will remind you when we get to that part as well. So coronary arteries, again, you can kind of see the heart behind me that fortunately it looks like we're looking at the anterior side, possibly not the posterior, but you have blood vessels that supply blood to the heart itself, right? So the heart is going to break off into these individual branches and actually keep that organ alive. The coronary arteries in the first part of the aorta, there's a right coronary artery, there's a left coronary artery. When you think of, and this is called the widowmaker, the left anterior descending, that if that actually becomes blocked or occluded, because any blood vessel in the heart or really throughout your body can suffer some type of plaque buildup or can throw a embolism, and it can actually impede that ability of the heart to be fed at lower levels. So the right coronary artery and the left coronary artery are actually responsible for feeding that big thing behind me. So again, and I want you to pull this page up in your text because it does get a little harder to see. Remember, I sent you anterior and the posterior side. Oh, anterior and posterior. One's in the front, one's in the back. But you can see where all those blood vessels or those coronary arteries break up and feed specific regions of the heart. Now, arteries do supply oxygen to different parts of the body, right? But that all comes out of the aorta. So all that blood that's pumped out from that left ventricle eventually comes out the aorta. Well, I can feel left and right carotid pulses. There's a right and a left subclavian, which is also fed as well. There's your brachial pulse. So again, that impulse is coming from that left ventricle itself. There's the radial and ulnar, and on the next page, it actually gives you better pictures with this, or I guess it's coming up a little bit later on. But we'll see the different pulse points, because I believe there's 6 that you need to be able to palpate and assess for on a patient. The arterioles and capillaries, those are smaller vessels. Okay? We start with an artery, we may go down to an arteriole, and then we get to a capillary level. But capillaries, and I would underline this part as well, capillaries connect arterioles to venules. Okay? Arterioles or venules, and if you think about it, that artery is going to eventually turn in, after it passes through a venule, to become a vein and deliver deoxygenated blood back to the side of the heart, whether it's the superior, means it's coming from up here, or inferior vena cava. And the venule is all the smallest branches of the veins. The vena cava, again, superior and inferior, really start with that because you need to know how deoxygenated blood gets back to the heart. It's through the superior, the inferior vena cava. So when we talk about why is this important? You know, y'all finished up with trauma, and we know that someone who's bleeding is losing certain things. Here we see what blood consists of, the red blood cells. Why are red blood cells important? Because they carry oxygen, right? And every portion of your body needs to be perfused. We'll see that a little later on. The white blood cells help with infection. Your platelets help give that blood its ability to clot. And plasma is the fluid that the cells actually float in. And this is why, if you think back to the burns that we did at the end of Module 5, oh, well, what is bad when someone is burned through this much of their body? They can actually lose that plasma as well. So those are the 4 components of blood. I will say that is an important thing to keep in mind: red blood cells, white blood cells, platelets, and of course the plasma. So blood pressure itself, again, and you've been taking blood pressures for a while, systolic and diastolic blood pressures, right? We've got those 2 numbers. The systolic should be up here while your diastolic should be up here. Well, why? Because the systolic pressure is at maximum pressure that's going to be generated by the left ventricle. We also can consider this the heart when it's at work. On the diastolic, the pressure against the artery walls while the left ventricle is at rest, right? And we start thinking about someone who is hypertensive and their blood pressure is typically 160 over 100. Well, does that really enable that left ventricle to get the rest that it needs, right? Think about a desired blood pressure. And again, this is all dependent on patient's weight and their size, but maybe 120 over 80 would be someone's blood pressure when it's controlled with medication. And without that, maybe they're sitting at that 160 over 120 all the time. So again, we look at some of the controllable risk factors. The hypertension is considered a controllable risk factor. Why? Because there's medication for it. Pulse points, and I would define this as a pulse is when an artery comes in close contact with a bone, right? And we'll see some of those different points on the body. You will need to be able to delineate between a peripheral pulse. If I could say the word, I could tell you to remember it. Peripheral pulse, that's in the extremities. And then the central pulses are things that are felt near the body's trunk. So carotid, well, I guess that's closer to the trunk. The femoral, here we go. So we look at these, the carotid and then the femoral, right? Those are closer to the trunk. A brachial, well, isn't that on an extremity? Yes, and whose pulse would we check at the brachial artery? Well, maybe that of a child, definitely an infant, because we don't want to put that pressure on the carotid neck just because of the airway. Most patients' pulses where you will assess if they are communicating with you, right, they're conscious and alert, we're going to check a radial pulse. If they're unconscious, then we check the carotid pulse, right? That goes right in line with the AHA guidelines. When we start worrying about the posterior tibial pulse, we want to make sure that that blood is indeed getting down all that way. If there's a fracture in the leg, this is why it's so important to make sure we're checking the pulses. And the same thing with the dorsalis pedis. Dorsalis pedis, someone who has this ganked up ankle, that's a highly proficient medical term, ganked up ankle. But if they've got a fracture and they don't have pulses to that, kind of think back to trauma, that moves that up the scale of importance, right? I have a pulseless extremity. We know that can only last, a couple of hours, and that's why they would be moved up on the priority chart. So cardiac output, volume of blood that passes through the heart in 1 minute. Okay, so here's a new term, cardiac output, referring to 1 minute of this actually taking place. How do we come up with that formula? You need to take the heart rate. I'll give you an easy one here, 60 beats a minute. My heart is beating at 60 times a minute. Great. Now, volume of blood ejected with each contraction. So we take that heart rate, we multiply it by that volume, and in this case, let's call it 10 milliliters, right? Every time that thing pumps, it's putting out 10 milliliters. Do you see how we get 60 times 10 equals 600 for our stroke volume, right? That's just what we're looking at for cardiac output over the course of 1 minute. You have to take that heart rate, check it for 15 seconds, multiply it by 4, times how much is coming out. That equals your cardiac output. Perfusion, and we should be familiar with perfusion as well. That's organs that are actually getting the oxygen that they need. So if it gets the oxygen it needs, it can also get rid of those waste products. But what do we need for good perfusion? Well, we need good perfusion to keep all of your cells alive and not worry about that buildup of the waste products. If perfusion fails, and there's multiple reasons that this will happen, cell death is going to happen, and eventually your patient is going to die. So that's why it's so important when we do our full assessment, right? We check the pulses, skin color, skin temperature, skin condition, just to make sure that the body is working in the process we refer to as homeostasis. Right? Homeostasis means they're getting the good stuff in and they're getting the bad stuff out. So chest pain, ischemia, which means there's decreased blood flow, right? The red blood cells that need to go to certain portions of the heart to keep it alive are now being impinged upon. They're not getting enough oxygen. Ischemic heart disease involves decreased blood flow to one or more portions of the heart. Again, and you can't tell as an EMT where that heart is actually being deprived of oxygen, which is awesome. When we look at the ALS intervention here, you can actually put someone on a cardiac monitor, and based on the rhythms that you're seeing or your partner would be seeing, that's something that they can alert the cath lab, and now there's a more expeditious route to their definitive care. But if blood flow is not restored, the tissue is going to die, right? Tissue dies in the heart, just like any other place on your body. The problem with this is that it does not have that ability to regenerate itself, right? Once that cell is dead, it's unfortunately dead. This is a pretty awesome thing too. This is 16.8 from page 636. We're looking at the atherosclerosis, buildup of calcium, cholesterol, plaque. The little circle here that you're looking at is a lumen, and a lumen is the passageway in which blood travels. But imagine when you've got this plaque and the narrowing of that artery, it's so much harder for blood to actually get through that. And if the heart rate is put at an increased demand, it's not going to be able to supply that appropriately. Then we may start seeing this angina pectoris or AMI, acute myocardial infarction, depending on how long this has progressed. But can lead to the occlusion of the arteries. And if you've ever heard the term, a 20% occlusion or a 50% occlusion, what that means is that lumen only has the ability to deliver a quarter or a half or whatever those numbers end up being of normal blood flow to the heart. Fat materials accumulate with age, right? So this is why we don't see a lot of 3 or 4-year-olds having heart attacks. If you remember that it's more common for infants and children to go into secondary cardiac arrest, which means they stop breathing first, and then the heart rate will subsequently follow. But big difference between the adult and the child. The thromboembolism, or embolism, it's some blood clot that's just breaking free, right? And so we see this a lot of times post-surgery, post-major surgery, like a hip surgery. This is why they wear things called TED hose, which can increase and decrease the pressure in the legs. Because as someone is sedentary for a while, if they've had something like a major surgery, they may actually have a clot that breaks free. And if that clot gets into the coronary artery, it's going to cause that heart to actually die. That's acute myocardial infarction. Infarction is just the dying of the tissue in there. So depending on where it could lodge in the brain. And again, there's so many places that could break free. We just don't know where it's going to get stuck, right? It can no longer follow that normal path that the blood would be traveling. CAD, or coronary artery disease, still the leading cause of death. The controllable risk factors, again, things such as diet, not smoking, right? Those are all controllable risk factors. When you look at an uncontrollable risk factor, gender, age, right? Family history, those are all things that are uncontrollable. So make sure you pay attention to controllable versus uncontrollable risk factors. If I'll give you an example where you have a 56-year-old male who is non-compliant with his blood pressure medication, what type of risk factor is he encountering? It's a controllable one, right? You can't control whether you're male or female, but you can control whether or not you take your medication, whether or not you smoke, and whether or not you're eating pork rinds at every meal. So the acute coronary syndrome, ACS, caused by myocardial ischemia. So heart muscle is not getting enough oxygen. And these are two of the things that show up on that first page. Over on 628, we start looking at angina pectoris and then the acute myocardial infarction. Remember, with an AMI, there's actually cell damage and death that is occurring. So angina pectoris, whatever you want to call it, that angina just occurs when the heart's need for oxygen exceeds the supply, right? I need this much blood coming in, but I'm only able to get this much. Why is that so important? Well, we think back to what's in the blood and what are their components. This one specifically, I'm worried about the red blood cells and its ability to get oxygen to the part of the heart that needs it. As patients describe this, it may be a crushing or a squeezing pain. When we start going through our op-curse, we'll look at each of those individually. But here does not usually lead to death or permanent heart damage. Okay? Angina pectoris usually does not lead to permanent damage of the heart. But if I've got a patient who is presenting with some type of chest pain or discomfort, I'm going to treat them all like they're having a myocardial infarction, right? We're going to give them the oxygen, position them appropriately, because really the only way you're going to make that determination is inside the hospital. So yeah, I can hope for the best, but in the back of my mind, and I saw this on Laura's lectures today, when we go through that medical, we start up here, right? What's the worst thing that could happen? And then if I assume it's a heart attack, when we get into the hospital, it's angina, and they were just having to be out of their nitro, but that spasming is now released. They feel better. Then that's a good day for everyone, right? We don't want to make assumptions whether it's this or that. Just treat it like it's the worst case scenario. The unstable angina, fewer stimuli than normal. So when we look at unstable, they don't have to be doing as much to produce that type of effect on them. In a stable angina, it's relieved by rest or nitroglycerin. What I've heard from most patients is, oh, look, you're prescribed nitro. Yeah, my doctor said if I start having this, chest pain, or if I'm doing something strenuous, I take the nitro, I rest, and that pain should be relieved. But when it's not relieved are typically the types of calls that you will get called for, right? And treat angina patient just like any AMI patient you would encounter. And now, what's different in the angina versus the AMI, acute myocardial infarction, there's actually death of the cells in the heart muscle, right? Once dead, cells cannot be revived. It doesn't mean the heart can't reconfigure a way to do that, but the longer that goes on, the less likely that is to occur. There's different medications, clot-busting medications, thrombolytics. Angioplasty is this kick-ass thing that's done as well. And if you ask during one of these Q&A times, we can pull up a couple of different videos. I can show you where they put this balloon in. It dilates that coronary vessel. But why that works? Because, right, you cannot just put a balloon in a hose and expect blood to course through that, right? The balloon's going to block. So they use these things called stents. They're wire mesh that expand out, and they help maintain that integrity of the vessel. There's also some pretty kick-ass treatments when we get into the, wow, I just lost what it was. Well, when we go into grafts, and we'll see this a little later on as well. I just get so excited, sometimes I brain fart on it. But your key for this is immediate transport, right? They need to be at definitive care. They need to be at a hospital. You can do a lot in the back of an ambulance, but again, you will always know you can do a lot more at a cath lab or in an ICU. So signs and symptoms of the AMI, different from the angina pain. Not always due to exertion, lasts 30 minutes to, again, potentially several hours, but not always relieved by rest or nitroglycerin. Again, one of the medications we looked at in the pharmacology was nitroglycerin. Why is nitroglycerin so beneficial to these patients is that it's actually a vasodilator. And if we can expand the pipes, or in this case, the coronary artery, then there's a better chance that we can increase the blood flow to the area which is currently being deprived of it. AMI and cardiac compromise, physical findings. We'll look at, I know there's a sheet that's coming up a little later on that'll look at this type of chest pain versus that type of chest pain. But I'm not in the habit of trying to decipher everything that's going on with the patient. We just realized, hey, their chest is hurting. Remember our philosophy on this. Let's treat it like the worst case scenario. The consequences of AMI, and that's a pretty serious one. Sudden death. Sudden death happens. Okay, I guess we'll go straight into CPR. Cardiogenic shock. Cardiogenic shock is something that typically develops after someone's had a heart attack. And then congestive heart failure, where there's a buildup of fluids typically caused by a left-sided heart failure. You'll see two. There's left-sided heart failure, which generally presents with the congestive heart failure, or what's known as pulmonary edema. When the right side of the heart fails, you may see that with pitting or pedal edema, so the legs are really swollen on that patient. But again, trying to differentiate this versus that in the field, it could also be that the left and the right side of the heart have failed, which is why immediate transport becomes so important. The heart abnormalities that are possible, PVCs or premature ventricular contractions. It's just throwing an early P wave in there before the heart can actually contract. Tachycardia, by definition, is a heart rate above 100, and bradycardia, by definition, is a heart rate that's below 60 beats a minute. And again, we need to get a patient history so I can find out, hey, is your pulse usually 100 as you're sitting down and resting? Because that may seem high to a lot of us, but on someone who's 80 years old and has a history of heart complications, maybe that is their typical resting pulse. So just because someone's tachycardic or bradycardic, it's not the worst clinical finding that you can have, but it is something that we need to do more investigative work about. And then ventricular tachycardia. Ventricular tachycardia is when the ventricles are the only part of the heart that are firing. All we're going to be able to do for them, if they're pulseless, they're not breathing, we'll start CPR. Defibrillation is awesome. You have, access to the AED, and as you grab that AED, patient's not breathing, doesn't have a pulse. We start our compressions until we can actually place the pads on the patient. But the AED is only going to shock rhythms that need to be shocked. Right? That's the greatest thing about an AED. You could train a monkey to do it. Put the AED on, it says shock, you hit the shock button. For asystole, this is a bad rhythm. Okay? This is the absence of all electrical activity. That it's been dead or ischemic for a long time, and almost all patients die that are in asystole because there's nothing to defibrillate, right? There's no way I can, hit an AED and say shock, shock, shock. So this always brings me up to a movie called Flatliners. Asystole is also considered a flatline. And if you watch this is dumb, it's 80 something, but they wait till the person's in asystole and they go ahead and shock the heart. That's a bunch of crap. It does not work. We think about an AED, and the only rhythm that the AED is going to recognize is your ventricular fibrillation. It's a defibrillator, and that's why it only works off of fibrillation. The cardiogenic shock, often caused by a heart attack, I think that is an important thing to note. So your patient has a silent MI, and 2 or 3 days later, you notice that he's a little more swollen. There's inadequate oxygen to the body tissues, and things can start to shut down. But again, this is often caused by a heart attack. That's where you tend to see cardiogenic shock. But the heart itself loses its efficiency, right? It doesn't pump as strong as it used to. And obviously, our goal is to recognize shock in early stages, compensated, decompensated, and ultimately irreversible, just like it sounds. So again, we want to be on these assessments, and when there's any doubt, it's transport efficiently, quickly, and of course, safely. Congestive heart failure. Again, when you look at the left ventricle, no longer to make up for the decreased heart function. And so that blood starts to back up. And when that blood is on the left-hand side of the heart, it's going to start building up into the lungs. The lungs become congested with fluid. It can also affect the right side of the heart, and that's what we call dependent edema. Dependent edema is similar to pressing your finger in someone's leg and it stays indented, right? That's got a lot of excess fluid in that, and that's what I associate with a right-sided heart failure. But the left-sided, congestive, it's kind of in the name, congested, the lungs become congested with fluid. You may hear some wet lung sounds or coughing up some pink frothy sputum, which is always delicious to think about. Hypertensive emergencies, the pressure starts to get above 180. Okay, that is a hypertensive emergency. The sudden severe headache is common. When I think of this patient, I'm automatically thinking about a stroke, right? They have a rapid onset of a headache. They've got that blood pressure, which is really high. But altered mental status could also show signs of pulmonary edema. This is part of that investigative work that we're doing. Let's try and find out what this is. And sometimes we find out what it is by finding out what it isn't. And that's something referred to as a rule out criteria. But if untreated, there you go. The stroke, well, probably the coolest thing not that can happen to the patient is the dissecting aortic aneurysm. It's where that heart just, it bursts, and all of those, that increased pressure on that blood vessel or the aorta just starts to tear away. And I know we'll see there's a difference in between a dissecting aortic aneurysm and regular heart attack. Not that we minimize either one of those, but on the next couple of slides, we'll look at those. And if I can find what page they are, I will certainly tell you. But transport patients quickly and safely. The dissecting aortic aneurysm is a really, really bad thing to have. Aortic aneurysm, there you go. Weakening of the vessels, easy for me to say, weakness in the wall of the aorta. And if this thing does rupture, imagine, where is all the blood from your body exiting before it goes to circulation? It's coming out the aorta. And now we're saying this aorta can be susceptible to rupture. So again, all that blood is just going to start filling up the abdominal cavity. It's not something I've seen anyone survive pre-hospital wise. Actually, in clinical rounds we were doing, my partner was in there, and the guy actually blew this AAA, and they clamped that thing immediately, and that was the only reason why they actually saved him, because he actually had the zipper and the chest was open. But if that would have happened prior to surgical intervention, how long does it take for all that blood to circulate through your aorta? What do you have? Somewhere between, 5.25 liters of blood in the average patient? And that blood will escape quickly out of that hole in the aorta. Primary cause, uncontrolled hypertension. So remember we talked about systolic versus diastolic. And if your systolic sits up here at 160 and your diastolic's always at 120, then obviously there's so much more pressure that's put on your blood vessels. The signs and symptoms of that, and this comes on the next page, and we'll kind of dissect each one of these quickly and safely. So this is a cool picture. I don't know. Here it is. So book-wise, this shows up on page 643. And when you look at the AMI, right, let's just call this a heart attack, gradual with additional symptoms. When you're dealing with the dissecting aneurysm, it's abrupt without additional symptoms, right? This comes on all of a sudden. This one might be slow, and then it starts to get worse. The quality of the pain, I think we asked them some things in our sample and our OPCURST history about, tell me about the pain. Right? Pain is different. Pain can tell you a lot of things about the patient. So it's a tightness, or it's a chest pressure, or the proverbial elephant feels like he's sitting on my chest. But notice over here on the dissecting aneurysm, it's a sharp or tearing sensation. That would be terrifying, right? You're just sitting around, it feels like the inside of my body is tearing. Yeah, that's scary. It's 911. Then we go back to that immediate or rapid transport. The severity of pain increases with time versus this one, it's maximum pain from the onset, right? And that's why I say, just know where this is at, page 643. The timing of your pain, when you think about the questionings, right? Why are we asking all these questions, all those things you've sat through with Bridget and done, and we ask them about pain? Well, on an AMI, it may come and go. That's what they mean by wax and wane. When you look over here, it does not abate once it has started. It means it's constant, right? That pain is going to be there. So is your pain constant? Does it come and go, right? That worst case scenario I'm building, if you're telling me all these things on the right-hand side, I'm thinking more of a dissecting aneurysm, I need to get my butt over to the hospital. Scene size up, scene safety, right? Scene safety comes first with everything that we do, but now we're getting into nature of illness. You may get some clues from dispatch, family members or bystanders. Again, you might not know until you actually get to the patient, but it comes out of a medical call. Now we know we're dealing with nature of illness. And remember, those nature of illness could be a cardiovascular issue like we're doing now, could be a respiratory, it could be OB or GYN that we're forced to deal with, but that's nature of illness. your general impression. And those of you in the summer class, because I can attest that we have your virtual ride-alongs in the one that's finishing up now, but there are some things you do with a general impression. We just say sick or not sick, right? Critical, not critical. But remember, a critical patient or a non-critical patient, a non-critical can also become a critical patient. But that's that general impression, right? I come, I look at the patient, what do I immediately think about them? Unresponsive and not breathing, well, that's a bad general impression. So start CPR and get your AED, right? We want to defibrillate if that's what the patient needs, but you need to keep oxygen moving to the brain, which is the whole process behind CPR. Airway and breathing, good numbers here. You have a SAT, so an oxygen saturation, we put a pulse ox on that person's periphery or their finger, and they're at 95% or less than that, we want to make sure we give them oxygen. If they're breathing on their own and have good tidal volume, a non-rebreathing mask at 15 liters a minute, right? It should make sense. They're breathing. They can take that oxygen in. But if they're not breathing, this is where we need to do that positive pressure ventilation. It's 100% oxygen, so we run that too at 15 liters a minute. But remember your numbers, somewhere between 10 to 12 breaths a minute is what you want to apply when you squeeze this bag, right? Nice and easy, just make the chest rise, but that equates to one breath approximately every 5 to 6 seconds. Pulmonary edema, depending on your protocols, you might have to bag them, or the continuous positive airway pressure, or what's referred to as a CPAP, right? Just depends on local protocols, but we'll look more at CPAP because it's a great treatment if you're actually able to utilize it. Circulation, pulse, skin, and capillary refill, right? Capillary refill, I'm pressing on the finger here. I blanch it. Does it come back in under 2 seconds or is it over 2 seconds? Is this cardiogenic shock, which we can really, aid them by making the patient comfortable, giving them oxygen, and of course that rapid transport as well. Under your transport decision, I'm gonna vote that we transport the patient. And decision based on ability to stabilize life threats during primary assessment. Is there an ALS unit that is going to meet with you, or do you drive for 5 minutes and get 5 minutes closer to that unit, right? These are all decisions that you're making in a split second for your patient. The history taking, so I'm now going to assume that my patient is conscious and he can talk to me. Remember, if you have a medical patient and they're unconscious, unresponsive, this is why we talk more to bystanders. Look for medical alert tags. If they have one of those, maybe they can tell you they have a problem with, heart issues or whatever that is. But now, if they are up and they're talking to us, signs and symptoms, right? Allergies, medication, pertinent history, last time they ate something, events leading up to it. From the S, we throw this Abkirst in there. Here's the onset. Oh, when did it start? Okay, it's been going on for 20 minutes. P, provoke. Does anything make this pain better or worse, right? I want to know that because if they sit in this position, it feels better, then didn't I kind of rule out the dissecting aneurysm at that point? So again, the quality of the pain, use their own words if you can. It's hard not to lead someone. Is this a sharp or a stabbing pain, or does it feel like this or that? So hopefully they can describe that for you. Pain radiates. So maybe that pain, we think about a AAA, starts and it actually includes up the back to the middle of the shoulder blades. Severity, I will always remind you to preface your scale. So on a scale of 1 to 10, 1 being nothing, 10 being the worst pain you've ever had in your life, where would you rank this? And then the T, does it come and go, right? Because we already know onset. I know it started 15 minutes ago. So on your T, don't just repeat your I, or on your T, don't just repeat your O. So again, is it constant? Is it dull? Right? All those things that we can associate with the T on our Abkirst. Physical exam, focus on cardiac and respiratory. Why do we have to focus on cardiac and respiratory? Because those two work hand in hand. You want to check the circulation. How's the pulse? Is it weak on this side? It's strong on that side. The respirations, how many times a minute are they breathing? And if they start to increase that, maybe that's a sign of shock that we're seeing in our patient. So we measure the vital signs. We want to make sure, if available, that pulse ox is on. But let's change it up. Let's not have a pulse ox, and let's have a patient that's experiencing this crushing chest pain, right? Just because you don't have a pulse ox and the ability to read that is under 94% or under 95, still give them oxygen, right? Patients that are having heart problems need supplemental oxygen. So if you happen to not have a pulse ox, don't withhold that oxygen and say, well, because the book said I just do it if it's 95 or below and we didn't have a pulse ox, right? Cardiac patients need oxygen. There's some area that's being deprived of it, and we want to make sure we restore that as best as we can. Vital signs are done every 5 minutes on your critical patient. If it does change significantly, we may assess it more than those every 5 minutes, or after we give a medication, we want to make sure we're reassessing their blood pressure, pulse, respirations. Sudden cardiac arrest, again, this just kicking into VFib or some other lethal rhythm for your patient. We start CPR and we get the AED. But reassess your interventions. This means if we've given aspirin, nitro, and we'll see there's a couple more different medications that we can give our patient, is it working, right? The goal is when you find this patient who's experiencing this chest pain, let's give them a chest pain rating of 8. Well, by the time we get to the hospital, have we made them pain-free? Did the nitro work? Did the aspirin work? Because now that heart muscle, hopefully, is no longer dying, right? So decreasing that number from where we started would be awesome. The reassess, rapid transport, it should say rapid patient transport, but safely, right? Because we got to do this stuff safely. And then, of course, documenting everything that you're doing. Let me move you over here because I just want to make sure I can see that. So position of comfort in your patient, typically that may be seated or upright, semi-Fowler's position. And now if there is any problem with their breathing because of a congestive heart failure, it's easier when that blood pools down to the bottom of the lungs. Oxygen, if indicated, awesome. Always give oxygen to your chest pain patient if you feel they will benefit from it. And depending on your protocols, aspirin and nitro. So aspirin is BA, okay? I love aspirin. It says low dose aspirin here. So these are actually 81 milligram tablets, or what's referred to as baby aspirin. When you give that aspirin, aspirin has the ability, it blocks the production of something known as thromboxane A, which is a potent platelet aggregate. So by giving aspirin, you make the blood slicker. Think about now, so would I want to give aspirin first or second? Well, nitro has a more rapid onset, right? We just came off pharmacology. So aspirin is actually something that should be chewed. Nitroglycerin, fill in the blank, is administered this way. And we would typically say sublingual. There are some sprays for nitro that are out there. And again, we'll look at some of the different ways that medication's given. But aspirin first, so we can make that blood slicker. And then as we give the nitro is a vasodilator, so it'll increase that blood that's available for coronary perfusion. Aspirin effects, okay. Don't give aspirin if there's a history of Ray's syndrome, or if they have an allergy to that. There could also be a history of some bleeding ulcers. Because if I make the blood slicker, could I make that worse as well? So I would say if there's any issues with that, that's why you're going to contact Meds Control. Again, nitro available forms, it could be a spray, it could be a tablet, but those are all designed to deliver 0.4 milligrams of that dose as you give it. Some of the side effects of nitro, it's not uncommon for a patient to experience a headache, right? Because we're dilating things, oh, maybe they have a side effect. There is one contraindication that you have to be aware of, and that's a systolic blood pressure of under 100. So again, if you have any of those contraindications, maybe we call your base hospital and get clearance for that, but we don't blindly give nitro to someone who has a systolic pressure of less than 100. Administering nitro, this gets into our rights of medications. I gotta have the right patient, the right dose, the right route, the right indication, and that it's not expired. And we can throw in the 6th right for medication, which is document. You always document if you've given a medication. That's just one. Make sure it's not expired. Make sure it's prescribed for the patient. That's good. But remember, we've got 6 rights moving forward on medications. Should have saw that in pharmacy. As far as wearing gloves, nitro is something that if your hand is sweaty, it can actually, get into your body that way. So we always wear gloves, but it's just a reminder that if you're giving a medication, you want to make sure if you touch that nitro that you have your appropriate PPE on. For the ECG, and this is getting into cardiac monitoring, something that you may be expected to assist with, but at this point, and it'll come in mod 6, where you actually look a little more at a P, QRS, and a T wave. But right now, just want you to know that cardiac monitoring is awesome. Because again, we can actually see the heart beating and what potential issues are with that. But there are some principles to minimize what's called artifact. Artifact is as you're trying to read that nice squiggly line that goes up and down and up and down, it has excess lines in that paper. So again, that's what artifact is. And as long as we put the leads on correctly, we're going to have the ability to minimize any artifact. Artifact is also something you can see driving down the road, which is why we want to make sure we put these things on properly so we have the best conduction to actually see what's going on with the heart. So how do we make sure? Don't put it over someone with the, full hair on their chest. When you do that, pads just actually sit on top and it doesn't adhere down to the skin. This is very similar to your AED pads, right? Would you put the pads, your AED on pads with someone with a hairy chest? Well, if you were, then you would not expect those AED pads to be able to read. So we want to make sure that we clear that portion of the chest as well. Confirm your placement. I think there's, we can see the 4-lead or we can see a 12-lead EKG that are coming up. But the leads right now that I have in my monitor say right arm, right leg, left leg. Great. And then as we get a little deeper into a 12-lead EKG, we'll actually see where those go as well. But cardiac monitoring is truly a portion of the advanced life support or what a paramedic would do, but it is awesome to be able to know where these things go. If some of you actually made it to your clinical time, and that's probably what I miss most about this, is y'all being able to go into the hospital and do stuff like this, because they put the 12-lead on, right? You got your V1, V2, V3, V4, V5, V6. These allow us, and again, I can see where this is in the book because it's way too small for me to read, but you can recognize, here we go. Just so you know, that's over on page 650, 650, where you can see that V1, V1 gets placed here, and this is the portion of the heart it's looking at. This lead here, when we look at V3, it's looking at that portion of the heart, right? And it's so important to find out where that abnormality or blockage is in the heart. So again, we can relay that information to the cath lab. Once electrodes are in place, it tells you to turn on the monitor. Okay, that's fine. But we print this sample rhythm strip, and if that rhythm strip does have the artifact, again, that means that something may be potentially loose on that, right? I always want to do this patient seated. I put the monitor on them. Okay, just nice, easy breaths for us, sir, because even the breathing pattern has the ability to show up with some additional artifact on it. Heart surgeries and assisted devices. So again, remind me, these here are I got some pretty cool videos on these things. Right? Heart operations have been around for a long time. That's what it is. It's a damn cabbage. I could not remember the term cabbage. It's because I don't eat meat anymore. But coronary artery bypass graft, that type of cabbage. You're like, well, cabbage isn't meat. Yeah, but what do you have with cabbage? Corned beef. So I'm going off on a tangent. Excuse me. But what they do with this is typically they'll take the saphenous vein out of the leg, and whatever part of the heart, which is actually ischemic or has died, you can sew that on, and it creates a bypass where now it's not going through the dead area, but you open up that blood vessel, and now it goes from here to here, and it still enables you to feed the heart. These are really amazing surgeries. What you generally see in someone who's had an open heart surgery, it talks about the long scar, affectionately referred to as a zipper, right? So if you see that and they got, you can know they probably experienced some type of open heart surgery. The coronary angioplasty, that's where that little balloon goes into the coronary artery. It blows up. But again, remember, you can't leave the balloon in there. You can't leave this inflated. So what happens is they put those stents in. It helps stabilize that portion of the coronary artery. And now you can deflate the balloon, pull it out. So if someone tells you they have a stent, stents are typically something you will associate with that coronary angioplasty. They had a stent here, stent here. You can have the same thing with a CABG. You might have had a quadruple bypass. What does that mean? Well, it means there's 4 bypasses that they've had in their heart or as the result of that surgery. May have the long chest scar. There you go. Treat chest pain patients who has had any of these procedures just like you would anyone else. Okay, just because they had a bypass graft, 8 years ago, doesn't mean that they're not having another AMI at this point in time. There's implanted cardiac pacemakers. Pacemakers are pretty cool as well because it does help to maintain that regular cardiac rhythm and rate. If you get a chance and you're either in the hospital or riding in an ambulance and that person has a pacemaker, you can generally see a pacer spike that's on there. And again, just ask your partner or anyone that you're working with. They want to show you these things because they are so cool. But they're implanted under this heavy muscle skin, typically on that upper left portion of the chest. You can see that as for most people, as they're laying back, it's just a little outline of the pacemaker, again, which looks just like that. I have one of these somewhere. It was actually from the late 50s. Texas Instruments actually made these things. And they've gone from being real heavy and bulky to, I have something like this in my body now, and honestly, most of the time, I don't even know it's there. And again, that's that same idea we want to have with our cardiac patients. And we'll find that out as we're getting their history, which is why in our medical stuff, it's more of an ask and answer, right? I ask my patient this, I find out all this history about them. Pacemakers can malfunction, syncope, or a near fainting episode. They get dizzy, they get weak, may actually slow down that heart rate. So again, as we check someone's pulse, hey, your pulse is 40. Oh, my pulse is never 40. I have a pacemaker. My pacemaker set at 72. So we transport those patients promptly, right? Do they need additional oxygen? Depends on your clinical findings. But again, if you suspect they need oxygen, never withhold oxygen from a patient who may benefit from it. There's AICDs, automated implanted cardiac defibrillators, that those patients who have actually survived a ventricular fibrillation event before can actually have this on, and it just shocks them as needed. Everybody who has one of these. And what's great is if you're actually touching them and that goes off, it is not going to affect you, right? Why does an AED have to shock at 200 joules, or why do we do that manually? It's because it's got to go through so much tissue, right? This thing is actually connected to the heart itself, so it's a much lower joule setting, and joules are just things we use to describe how much energy we're shocking someone at. But if the electricity is low, it will not affect you, and it's not because it's connected right to the heart itself. The external defibrillator vest with a built-in monitoring device and has electrodes in that. It is attached to a monitor, and this gives high energy shocks. Right? It gives high energy shocks because it's got to go through the adipose tissue, the muscle as well, so it can actually go down and defibrillate. But if you can, leave the vest in place unless it inhibits your ability to do compressions. But then, can you think about it? If you had to take that vest off, what should be placed on that patient? We need to make sure that the AED is in place for them. The LVAD, left ventricular assisted devices, those are typically a bridge to someone who's going to receive a heart transplant. That it may be, when you talk about pulsate or continuous, it may be going, or it may be, but family members, the patient themselves, they know so much about these. Because if something happens, like let's say you lose the power and you've got the battery hooked up to your LVAD, then they know that's a critical thing and they have to get themselves to the hospital, right? So patients are really your best information for the left ventricular assisted device. Cardiac arrest. Well, cardiac arrest, you're not breathing, you don't have a pulse. The complete cessation of cardiac activity. There are rhythms like ventricular fibrillation where the heart is still going through, and I don't want to say it's beating, but it's got electrical activity. That is better than being in asystole, right? Because asystole means that that whole heart has actually stopped. What do we do for someone like that? Well, you're not breathing, you don't have a pulse. We better start pounding on that chest 100 to 120 times a minute and make sure we get the AED there. The AED, this is awesome. Analyze that electrical heart signals, but identifies VFib, okay? An AED will only shock ventricular fibrillation. There is another rhythm where someone could be in ventricular tachycardia, but that really requires what's known as a sync cardiovert. So just know the AED is designed to recognize and treat ventricular fibrillation by giving a shock to the heart, which hopefully can reestablish those pathways of conduction. Okay, but there's only one rhythm that the AED is going to shock, and that's ventricular fibrillation. Automated external defibrillators, again, that I have that one. I don't know the ones we have in class. Can't remember right now. There's probably one sitting here somewhere. Oh shit, yeah. So again, the AED, right? The AEDs are great. These are when we get back into class and we can just review those. The AED skill sheet is pretty easy if you've taken your CPR class, which I know you all have. So we'll run through that as well again, but if there's questions that come up on it, let me know and we'll certainly answer those in our Q&A times. The automated external defibrillator ALS intercept. So let's say you were utilizing an AED and you happen to get a pulse back. Okay. In CPR terms, that's referred to as ROSC, return of spontaneous circulation. Excellent. Now, we want to continue to ventilate that patient, watch their oxygen stats, right, and try and keep those above the 94% range. Your blood pressure, obviously, we're hoping for at least a systolic of 90. The glucose levels, these are some of our differential diagnosis. What is the glucose on this person? But we transport them to the hospital. And this is where the team approach comes in. When you think of the chain of survival from American Heart, early access or rapidly calling 911, early CPR, early AED, early advanced life support, and then early definitive care, right? Get him to the hospital and the cath lab. So using an AED itself, I'm clear, you're clear, we're all clear before I hit that shock button. Don't defibrillate a patient that's still in pooled water unless you want to fry yourself and the patient when they're touching metal. Or we can add another one here. There's that hairy chest, right? Because then you know the pads aren't going to stick and probably wouldn't have analyzed in the first place. Remove nitro patches or anything, again, that's on your patient, whatever that medication patch may be. Gloved hand, but kind of towel dry that. There we go, shaving the chest. Perform spinal immobilization for trauma patients. So again, if there's someone walking down my street and they collapse in the middle, then that's someone who's going to be put on a spine board and will spinally immobilize that patient. Because what happened to their head or neck as they fell? ALS assistance in a tiered system. Tiered system recognizes that we dispatch certain units to different calls. So hopefully this went out ALS right away, but you don't know. Maybe you just respond, and anyone can respond to the patient in chest pain. It's once it becomes a cardiac arrest, hey, now we're thinking we want to have a different level or providers that can provide different care, but ultimately it's about getting to the hospital efficiently and safely. Cardiac arrest and transport, I think this comes up. Stop the vehicle, right? There may be so much artifact that's going on. Begin CPR if the AED is not immediately available. Link 2 in your chain of survival, but call for ALS backup if you can. And that's even on your sheet, right? Oh, consider the need for ALS. Well, yeah, we want to get them if we can. If it does say deliver a shock, you hit that shock button and then you continue on. So here's ROSC, return of spontaneous circulation. Monitor for respirations. If they're still not breathing, but they have a pulse, 10 to 12 breaths per minute. right? 95 to 99% for your oxygen, that percentage that you get off of your pulse ox. See if you can actually get a blood pressure on that patient. Can they follow any commands? You know, some people that get defibrillated, you know, and it's a rare occasion, may kind of come out and they're trying to communicate with you, whatever it is, but we want to make sure we get them to the hospital, because just like this happened so suddenly, it doesn't mean that they can't revert back to that same type of rhythm. So just one quick review question for you. And again, hopefully you'll go through these and we'll have some more questions that come up over the next couple of days. But all the following are common signs and symptoms of cardiac ischemia. So signs of the heart not getting enough oxygen. And every time we throw you an except, notice that that's capitalized, right? It's a little bolder than your regular words. So which one of these is not seen with cardiac ischemia? Headache, chest pressure, shortness of breath, anxiety, or restlessness. Well, we should know that headache, right? Headache, click on this. Cardiac ischemia occurs when the heart's demand for oxygen exceeds the available supply. So again, all those other ones that you have certainly are associated with the cardiac ischemia, but headache is not, and that's why it's an except on there. So I'm going to stop my share. I'm going to move myself over to this screen here and say, I will see you guys in the morning, and we will cover any questions that you had in regards to this chapter. So cool. And remind me about those videos, because those are really awesome as well.